if you think about all the structures in your limb, you've got skin, you've got fatty tissue, you've got muscle, you've got tendon, bone, joints, and then the things that most people kind of know about a little, or if they start to bother you, is the pipes, the arteries and veins, and the nerves, right? So any one of those structures or combination, if they're not working well, can cause pain. But tonight we're going to focus on a couple of vascular specific topics since the vascular surgeon is talking to you. And we'll have a conversation about that. Part of the circulatory system. So this is all what 8th grade biology or something we kind of remember. I can't remember. So the heart is the pump, and then you have a set of outbound pipes called arteries. They're usually high pressure pipes, taking that velocity out of the heart, distributing the blood downstream, go through a capillary bed, and then you got a low pressure circuit, which are the return pipes, which are the veins. So interestingly, there's 2 circuits connected to the heart. So obviously we assume the red is the oxygenated blood. So to the periphery, which we're going to focus on today, the outbound pipes are oxygenated and the veins are deoxygenated. But the inner circle that goes to the lungs, colors are backwards. The outbound pipe is the artery, but it's carrying deoxygenated blood. So it's not an error in the drawing, it's the physiology of what we're dealing with. So today we're going to focus on the red and the blue loop on the bottom there. And so this is the arterial major arteries of the body depicted. The heart is connected to the aorta, which is the straight pipe, the main distribution manifold, if you will. And once it hits the diaphragm here, this is the aorta in the abdomen. And then the circulation to the limb is like the terminal part of the aorta, these arteries in the pelvis called the iliac arteries. And then you have from the groin or the inguinal ligament to the knee, that's the femoral artery to about here. Then you have what's called the popliteal artery, and then you have the tibial arteries into the foot. So there's basically, this is the backup called the profunda and the femoral, but then there are actually 3 tibial arteries, 2 that go straight into the foot, 1 that goes into the ankle. The reason I show this to you is not because you're having a quiz on what those names were, but basically think of it as 3 zones. So you got from the belly button to the groin is zone 1, from the groin to the knee is zone 2, and below the knee is zone 3. So just think about it in those terms, okay? Because it'll make more sense as we talk about the disease processes and things. So the pipes, these are the high pressure pipes. So again, trying to make it kind of more quantifiably understandable instead of complicating it. Think of it as you got a pipe in your house, what kind of problems you have? They get blocked or they explode, right? Same thing. So you have diseases that cause obstruction, which is blocked, and then you have diseases that are related to expansion of the artery, okay? And then you can subdivide those into 2 other categories: acute, which is like immediate, and chronic, which is technically more than a couple of weeks or more slow, long-standing. And then you can apply that same methodology on both sides of the equation, both to obstructions and expansions. And then that gives you a whole subset of diseases that go along in those buckets, okay? Because I look at it like the physiology. So it doesn't matter what you call the disease, A, B, or C, they behave kind of the same way. And so that's a good way to think about it. They present a little different, and the implications are a little different. So, and we're going to talk about basically a couple of arterial examples and a couple of venous examples, so some high pressure and low pressure. And there are going to be more of the common things that you see, but I threw in one of the more dangerous things just to spice it up a little bit. So again, on the obstruction side, acute. So what happens if you acutely lose your circulation? So think of it's like strangling your leg, right? So what do you think that's going to present with? How would the patient present? It's going to hurt. going to look white because you're not getting the pink perfusion, right? You don't have the backup circulation developed because you just shut it off, so it didn't happen over time. The tissues are going to starve. So we have the symptoms of pain, pulselessness, so you can't feel the pulse, pallor, the white, cold, and paresthesias are numbness and tingling because the nerves aren't happy. And that's the lack of blood supply and the tissue compromise we call ischemia. And then if it goes on too long, you have cells actually die. And you got about an 8-hour window to get that corrected. You lose, if you didn't have vascular disease and you lost the circulation abruptly, you got to get revascularized typically within 6 to 8 hours. So it's considered a vascular emergency if that happens. So file that away, that's the dramatic one. And if it were to sometimes happen, there are conditions that commonly people have, and they don't even get the association. And we'll talk a little about that as we get into this. And some examples are embolism, and what I was referring to is a cardiac embolus. People with atrial fibrillation can have clots, get a funny heartbeat, change your rhythm, boom, clot gets kicked out, goes down your leg, and then you have a cold leg. So that's a common thing that we see in the cardiovascular world. Thrombosis just means clotting, so people can just clot de novo or for no other reason. Inherited conditions will cause that as well. Dissection, that's a term that goes along somewhat with aneurysmal disease, but basically it refers to a tear on the inside layer of the artery where it delaminates. Artery is living tissue made of several layers, and if you get the shear forces hitting it correctly or properly or improperly, you can actually tear the lining off. So think of like power washing your deck and peeling the paint off. That's what happens. That's a dissection. And then that flap can obstruct the blood flow. Trauma, obviously, you could injure the vessel and obstruct the blood flow, or you could dislocate your elbow and stretch it or compress it, and then you lose the circulation that way, or a knee. Those are the common things. Or another phenomenon called a compartment syndrome, which we can talk about a little later as well. Compare that to chronic conditions. The most common is atherosclerosis, and I'm sure we all know something about atherosclerosis. So that's a gradual loss of circulation over time, and you have time to compensate and build up collaterals. So as the circulation kind of shuts down on one end, the body's trying to open up and compensate for it on a different end over time. Presentation's a little different. Flow is somewhat compensated, and the symptoms are more graded in severity. Tissues are still starved of oxygen and nutrients, and you can get tissue loss and other symptoms along the way, but it's a more slowly progressive over time type of approach. When we talk about the expansion side of things, these are aneurysms. Aneurysms, trauma, dissection. A fistula is an abnormal connection between an artery and a vein. That can occur if we create it, like for dialysis access. It can also occur if you have like an aneurysm eroding into an adjacent vein, or under traumatic type of circumstances as well. But with expansion in an acute phase, it's about pain. The expansion tears tissue. You can have hemorrhage associated with it, which also tears tissue. So you can have the pain aspect of it. You can have the expansion aspect of it. You can have the hemorrhage aspect of it, which could also lead to low blood pressure, organ failure, death, just from the bleeding component as well. And interestingly, on top of that, you can develop a slow flow state, or in an aneurysm, you have areas where the flow is stagnant and where you actually have laminated clot. And those can break off and cause acute obstruction on top of this other phenomenon as well. So you get a mixed bag. You can have somebody who's bleeding, but then they embolize to their leg, and then they have both two problems. They got the acute phase, and once you fix that, you figure out, oh my God, they don't have circulation to their limb, and you have to rescue that as well. And finally, Chronic is more of just the pain, pressure, swelling, influence on adjacent organs. So that's basically the paradigm that I use, and it doesn't matter, there's a whole different set of conditions that apply to those, but they kind of behave the same way within the same bucket. So we're going to start the conversation with chronic vascular arterial disease, atherosclerosis. So picture on the left is untreated. That is our iliac artery up here, because here's the aorta. This is the inguinal ligament, so you all know where you are. So this is the first zone, zone 1. And you see that? What do you see? You see an obstruction, but then look at all this other stuff here. What are those? That's the backup circulation. Those are collaterals. Okay? So the body says, well, I can't go down the main channel. Let's go down the back channel. And that's the main perfusion. So you can see how small they are relative to the main pipe. And you can imagine the resistance in those vessels compared to a big open pipe is going to be greater. And so you're not going to get as much flow through a collateral as you are through the main channel by definition. There are more of them, but even if you had 10 times what you see there, it's still not enough to match the wide open normal pipe. Now, on the right, or the left, yeah, the right side, you're right, this is after we fixed it. So this is stented. What do you see in the collaterals? You don't see them. Why is that? Flow's preferentially going past that down the proper channel. The collaterals are still there, but they're underperfused because the body doesn't need them as much. So when I do a case like this in the lab and we fix somebody with a stent, this is a common thing that you actually see, but it's kind of fun to point out because that's very dramatic. You're like, what happened to all the circulation? Well, the circulation is going where it should be, so you don't see those collaterals. And you know the fix is good because the collaterals went away. If I put a stent in and there was some downstream obstruction and it still wasn't quite physiologically right, you'd still see some of those collaterals. And that's a cue to me as the surgeon. It's like, well, maybe we've got an issue here that we still have to investigate or we haven't fixed it all the way. So now when the doctor shows you this, you know what it's up to, right? So PAD, peripheral arterial disease, atherosclerosis, is extremely common. The thing about PAD, you got to think of that, it's a systemic disease. So we're focusing on the effects of the legs, but the same principles apply to every organ in the body. Heart disease, this is it, specific to the heart. Kidney disease, this is part of it. Strokes, this is it. Same sort of thing, same disease. Think of it as toxins in the sewer pipe. Lots of toxins, lots of gradient moving that into the periphery and leaching off, and there's a systemic effect from it. So it's the same general concept, just affecting different organs. And everybody's more familiar with cardiac disease and heart attack and stroke. But actually, the commonest place to get this is in your legs. If you have heart disease, you got leg disease. So in order of kind of prevalence, it's actually PAD is more common than coronary artery disease, which is more common than stroke or cerebrovascular disease. That's the rank order. And they're huge numbers. 14% of the general population, a third of diabetics over 50 years, and 20% of people 65 and older. And most people with PAD are non-symptomatic. So that means the people who are coming in and the ones being treated is only the tip of the iceberg. So something to think about. So the common symptoms start with, okay, you can be non-symptomatic, so okay, that's one. But then the next phase is what we call claudication. And that literally means to limp, okay? So that's how it was initially described. In claudicants, it's pain, weakness, tiredness, heaviness, numbness, muscle cramping with exertion. You're using the muscle, can't get the fuel fast enough, and it hurts. It's exercise dependent. That is the hallmark of claudication. The next phase, if it gets worse, if you have a claudicator and their symptoms are progressing, you can get to basically tissue loss is the simple way I call it. And it's sores or wounds or ulcers or slow healing wounds. It's just, you're trying to water your tomato plants with a kink in the hose. It just doesn't do very well. And then the plants start to die. You can get noticeable changes in color, temperature, compare the other limb. The hair on your feet and toes are gone, or your lower leg and your toenails and don't grow so well. So that's classic progression of vascular disease. So Fontaine in the 50s set up a classification just outlining that. Stage 1 is the non-symptomatic patient. Stage 2 is the claudicator. And he broke it down into A and B at 200 meters. Well, how much is 200 meters? I don't know. It's 1/8 of a mile. Okay. Or 8 to 10 city blocks. If you live in Chicago, it's 10 blocks. If you live in New York, it's 8 blocks. Okay. I don't know what a Fairbanks block is. I haven't measured it. And then more than 200 meters. So it's not very much. You think about it. 1/8 of a mile, that's 10 blocks. So it's people who can't walk that far and then are having pain and limitations. When you get to stage 3, this is kind of the more severe tissue loss. Rest pain is what we call it, but it's really boils down to gravity-dependent circulation. So think about it, rest pain. You're laying at night trying to rest, and your legs are going to sleep because you don't have enough perfusion. How do you think you compensate for that? Leg over the edge of the bed, right? And you're getting the gravity effect trying to pull more blood into that compromised limb. That's classic rest pain. And then stage 4 is necrosis, wounds, gangrene, tissue death. So that's the progression of vascular disease. So claudication, getting back to stage 2, is exercise related. You can have it in any muscle group. So you can have it up in the buttock and the thigh area. So I'm going to step down to the middle of the slide. See that pain one joint level below the stenosis? So where it hurts you is one joint level lower than the actual blockage. Again, that's another doctor trick to know what we're looking for. So hip and buttock claudication, thigh claudication, the blockages are going to be which zone? Zone 1, that's correct. So up here. So to hurt here, you got to have the blockage up here. If you got it in your calf, that's the commonest place. Where do you think? 1, 2, or 3? 2. Correct. So again, you typically have it above the knee in order for hurting your calf. And if it hurts you in the foot, zone 3. Okay. So pretty simple. Now you're all ready for vascular surgery. Okay. Spinal nerve compression, back pain, right? So what's the differentiating factor? Somebody comes in and says, oh yeah, I hurt when I walk, my legs are numb. Okay, I'm worried about claudication. And they say, but you know what? It's worse when I just stand there. It's like, oh, my back kills me and my legs are numb. Spinal disease. So that's how you can differentiate some of that. But nothing in medicine is 100%. And there are people who have what we call pseudo-claudication, which it looks like claudication, smells like claudication, you think it's claudication, and it's spinal disease. So take that for what it's worth. But that's a possibility as well. Fixed obstructions in the blood supply to the muscles that we talked about, downstream symptoms due to the supply mismatch, and the muscles are running on anaerobic metabolism. They're creating acid. The acid and the anaerobic metabolism component irritates the nerve, brings out other pain-related substance, and it hurts. That's the bottom line, and that's the physiology. Okay, what about a cramp at night? A lot of us have that, right? Not vascular, okay? It's a muscle nerve stretch problem. You may have pulses, you may not have pulses, but the night cramping that a lot of us suffer from is a non-vascular issue at all. So I threw that in there because a lot of people have it, and I get asked that question 4 times a week at a minimum. So how do we deal with this, or how do we go about approaching and working it up? There are basically three things we focus on. A, where are the blockages? B, are they significant? So think about that statement, okay? Most people with actual PAD don't have symptoms, okay? So if you had 100% block in your femoral artery and you found it incidentally on a CAT scan, and you go and your doctor says, go see the vascular surgeon, and we're having a conversation about what your symptoms are and what's going on, I say, well, how far can you walk? Like, I can walk 5 miles, you know? Okay, how about uphill? Yeah, no problem. You have any wounds? No? Okay, what are we gonna do with that? Medical treatment, or essentially nothing, simple things. Healthy living, we'll talk about that in a minute too, okay? But it's basically risk factors. I'm not gonna say we're gonna put a stent in you. I'm not gonna bypass you. Like, that's crazy. But that's it. So there is somewhat of a disconnect we see between actual blockages and physiology for lots of different reasons. And so I think we can see on a CAT scan, you can find these things all day long. But the question really is it really causing an impact? Is it causing you harm? Is it interfering with your quality of life? Is it putting your limb in jeopardy? Then that's a different story. So then we treat those. So that to me is important. And then obviously treatment if it's significant enough. So we take a history, we see what the problem is, we get the story of what's going on. We do a physical exam to get some objective evidence to see, are these things behaving, or do you see the clinical characteristics that you expected from the history? Does that add more information? And then for physiologic significance, we do something really simple called an ABI, ankle brachial index. And what that is, it's a series of blood pressures in your arm and blood pressures at your ankle, and you make a ratio. And that gives you kind of a grading system of impact. So, and then you can do it after exercise. So you can put somebody on a treadmill or have them do toe stands if they can't walk a treadmill, and you stress them and see how it changes. And that's really important, especially for zone 1 obstructions. Because if you think of those iliac arteries, they're higher in the tree. And so you may have a lot more collaterals. So I see this all the time. People may have a mild pulse reduction at rest or maybe not. Their ABIs at rest, the physician ordered a resting ABI only, and it's like 0.85, 0.9. But they're really giving you a story that sounds like, well, they've got some legitimate issue here. You put them on the treadmill and then it flushes out the difference. So that is an important nuance in the testing as well. Do it at rest, stress them, and see how it goes. And so here's kind of the numbers that we look at. Normal is 90% to 130%. And then abnormal is less than 90%. And then you can see 50% severe, and 75 is kind of break point between mid and moderate and mild. But that's basically what we do. We break it down so we have some objective evidence. And then when we treat people, we do the ABIs again and we compare them. Did it work? Did it not work? How much ABI improvement do you have? So you can monitor that pretty consistently. Okay. So chronic limb ischemia, when you get into those stage 3 and 4, again, that's tissue loss, more severe. It's responsible for over 100,000 amputations each year, like below knee and above knee amputations. Major deal. So in the communities I work at, that number's pretty low. That's my job, save limbs. You try not to take the limb off because there is a consequence. Not just the loss of the limb itself. But if you take a leg off, half of those people are going to be dead in 5 years. So there's a huge mortality impact in addition to the quality of life. So, you know, they deteriorate very quickly. It's got a 50% 5-year survival. I mean, it's like cancer. It's a bad form of cancer. And again, mortality rate's high and amputation rate in that first year. So it's very important if you get wounds that don't heal, you have rest pain, you get gangrene, you know, those types of stuff, those types of symptoms and presentation, you need to be on it. You can't wait 6 months to go to your primary care doc. You can't wait 6 months to get to the vascular surgeon. Because if you don't get on it and you end up with an amputation and tissue loss, you know, your mortality is compromised. Or mortality is increased, your life is compromised. So I think that's one of those take-home messages you need to take home with you. All right, so treatment. I think we actually covered a lot of this already, right? So we're just going to skip through this. Claudication, benign, the non-symptomatic patient, you're going to do risk factor modification. So those are 4 of the 5 risk factors. The 5th one is your genetics. You can't do anything about that, but every single one of those other ones you can do something about. You know, so I know we all know it. I'm not going to beat the dead horse, but just if you've got any of those risk factors and you got vascular disease, be proactive, healthy living, focus on that. It makes a difference. And exercise and antiplatelet therapy, which is the fancy word for like aspirin or Plavix, something where your blood elements don't stick together. Exercise is really the key. Exercise is very important. And what we're talking about is exercise. You can get on a bike, you can walk, you can run. But usually, like for exercise treatments, it's walking 3 to 4 days a week for half hour a day. Not very much. But if you do that, you're a claudicator and you walk consistently, you can double your pain-free walking distance in 12 months. You can raise your ABI by at least 10%. Okay? So what does that mean? So, patient who is non-symptomatic, we know about already. What about if you're mildly symptomatic? I can walk a mile. Okay? So if I walk every day or, 3 or 4 times a week, double your pain-free walking distance over the course of a year means that I can now walk 2 miles pain-free. So what can you do with a range of 2 miles? You can walk Costco, you can go to Fred Meyer, you can do your grocery shopping, you might go out and have a little fun, you can do a little bike ride. Okay, pretty good. Do you need treatment beyond that? Nope. So what if you're the postman and you can only walk 2 blocks? What's up with that? Interferes with my job. My quality of life is terrible. I can't do anything. I'm stuck in the house. I'm miserable when I try to walk. So that puts you in kind of like the severe impairment, lifestyle limiting, failed medical management. And then we have a conversation about revascularization, which is elective. You're not going to lose your leg over it, but it's trying to improve your quality of life. Let you walk better, get back in the game, enjoy yourself, do things, be active. But then I can put your stents in or bypass you. Usually it's stents nowadays. But at that point, you have to own that. You got to stop smoking. You got to control your diabetes. And if you don't, it's only going to come back or get worse. So if you own it and care for it and concentrate on it and keep active, you'll get some longevity out of the treatment. Okay? The stage 3 and 4 stuff, the rest pain, ulcers, gangrene, again, that's limb threatening. You don't get more blood, tissue gets lost, tissue at risk. So everybody gets revascularized, whether it's a bypass or an endovascular solution. Rest pain, ulcers, gangrene, usually it's more than one level. So now you've got zone 3 and zone 2, or 1, 2, and 3 all at once. So you have multiple levels that you're targeting, and you're working to get more blood from the top of the tree down to the foot. that's the approach. Okay, any questions? So neuropathy is interesting because, so neuropathy is nerve dysfunction, numbness and tingling that people have. So primarily speaking, neuropathy is unrelated. It's a nerve condition. It's a dysfunction of the nerve. But what I said earlier is that if you starve the tissue, obviously the nerves are going to be affected. So you can get a neuropathy from a lack of circulation, and you can get a neuropathy from a primary nerve dysfunction or a pinched nerve in your back or some other condition. So when people come into my office and say I have neuropathy, I assume it's a vascular affected neuropathy until I prove that it's not. So it's I commonly see that where people are sent in and say, oh, I have neuropathy. Well, they have untreated vascular disease. So technically, it's, when you say neuropathy, I think of a non-vascular condition, but there is overlap in those symptoms, and you have to assume it's a vascular problem until you prove otherwise. So could it be spinal disease? Sure. Could it be vascular disease? Sure. But until you've eliminated the spine and then you've eliminated the circulation as the cause, then you say, okay, well, it's primary neuropathy and it could be related to your diabetes or some other neurodegenerative. What is neuropathy? Is it numbness? Yeah, it's usually a presentation of pain or numbness or tingling, and it's constant, doesn't really get better. So that's typically what the term neuropathy refers to. But if you come in with those neuropathic symptoms and you have a ABI of 85% at rest and after exercise, I can't reconcile the amount of perfusion to nerve dysfunction. It just doesn't add up. So that would merit more of a workup to find what's causing the nerve irritation otherwise. Yeah.
I think when you showed that something like 20% or something like that over 65
Yep.
have this issue, but then you said that 75% is not, you don't know about it, nobody knows about it.
Yeah.
So do I take away from this presentation that if you don't have those symptoms, you're good to go?
No. You take away the symptoms, that if you don't have those symptoms, did you see the other part of the slide that said risk factors?
Yeah.
Okay. So if you were a smoker, okay, and you don't have symptoms, you could still have PAD unless somebody's worked you up. Or you might, if you have coronary disease, let's say I had some angina or have a heart problem and I smoked, but my legs are still fine, you have likely plaque in your artery. Again, it may not be symptomatic, but it's a systemic disease. So if it hits you here and it's all in every part of your circulation, it's likely going to be here because that's more common. So that's the take-home message, is you may not be symptomatic, but if you have a lot of risk factors, you probably have it in there. Now that actually brings up, I'm going to go off track here a little bit, but the question is, well, do we screen people for this? Do we be proactive and hunt all this stuff down? And there were several studies done, but the bottom line is, even if you just do ABIs on people, and you say, oh, you got vascular disease, let's just check your ankle brachial index to see if you're in the ballpark. The large studies don't show that there's much benefit for the money that you spend. So you're better off either, if you've got the risk factors, just control them, or when you start to get symptomatic, don't blow it off and just come in and get it evaluated, because that's your trigger to kind of get into the system. So we don't do prophylactic ABI screening from, just generally speaking, but there are like services like Lifeline screening that will do that on people who, if you want to get your ABI checked just to see, but it's, but that's not typical mainstream, medical practice, if you will. It's just check in to see. So, all right, any other questions? Yeah.
So
Yeah.
Could that be neuropathy or vascular? I have a large female family history of vascular, so could I ask my doctor to come to you or less?
Okay, so y'all hear the question? Basically, somebody who can walk and not really limited, but when they sit a lot and then have trouble getting up and then they have difficulty after that. So that speaks more to, on first pass, speaks more towards a spine problem or a pinch nerve, okay? Because what's happening is when you sit a lot, what do you got? Gravity, crushing your spine, right? Bringing it down, pinching the nerve roots, causing you to have difficulty when you just stand. It's not exercise, because if you walk 4 miles, I mean, that's not, you should be, if that were vascular, you should be hurting with that. So it's non-exercise induced, and it's more related to sitting. So that's kind of a typical spine presentation, if you will. So that's how we differentiate it. Yeah.
Does this slowing off and stuff happen just in the blood that's going from the heart feeding the tissue and not the return blood?
One more time, I'm sorry.
Okay, the slowing off that you mentioned, or the clotting that could take place, or the blockage, it's always going from the heart to like the feet and not any blood returning from the feet toward the heart.
Yeah, so these are primarily the arterial, that was an arterial condition. So this is the outflow pipe, high pressure, this is where it's common. Okay, so I see I'm taking a lot more time, so I'm gonna fast forward through this a little bit and we'll talk about the other side of the equation, okay? So acute limb ischemia, like I said, it's like you're strangling off the blood supply, threaten the limb viability, you don't have the collaterals, and it's an urgent condition because you got to get blood there more timely. 30-day mortality and amputation rate under those circumstances is 10 to 15%. So it's pretty significant. A lot of complications when you get into those kind of conditions. It can happen with arterial embolism like we talked about, from like atrial fibrillation or the aorta. Arterial thrombosis is basically clot formation related to plaque disruption or clot that just happens from a hypercoagulable condition. You got, like within minutes to hours, you have symptoms and you've got 6 to 8 hours to fix it and get it in. So that gets you back into it's the acute version of the chronic limb loss type of circumstance, but more tissue is at jeopardy. The hallmark to that is the nerve. The nerve is kind of the indicator. If you're getting those numbness and tingling and paresthesias on an acute basis, the nerve is the most sensitive tissue and the first to react. So if you lose the circulation, you're getting numbness, tingling, or paralysis, major, major urgent problem. Because if you don't get it and you get to paralysis, even if we revascularize you, you're likely going to lose your leg. So that's something that, heaven forbid, if it happened, don't wait around, go to the ER, get it checked out. All right, now we're going to talk about the vein circuit. Okay? So these conditions, I mean, this is the venous system, and it fairly closely parallels the arteries. They live next to each other. So you've got, instead of the aorta, you got the vena cava, which is the pipe here in the middle. You got iliac veins. You got femoral veins, popliteal veins, and tibial veins. The tibial veins in the lower leg are paired, so you actually have 2 to 1. So one artery, so you have 3 tibial arteries, you have 6 tibial veins. Veins have redundancy, sometimes they're duplicated. So again, these are low pressure pipes, and they behave a little differently. You also have a backup set. So when I talk to patients, is that you actually have 3 kinds of veins in your legs. You got the main deep veins, which are the primary return. You have a superficial network, so superficial veins, greater saphenous and lesser saphenous, and then you have perforators that connect the 2 systems. So think of it like a ladder, one oriented towards the skin, one down deep, some in between. And veins also have check valves, Why? Think about in the legs. You're trying to get blood low pressure uphill. How does that work? You move, muscle squeeze, squeezes the blood up in the vein, and then, oh, I want to catch it so it doesn't go down again. So the valve closes, okay? And you kind of get this stair-step flow upward towards the heart. What if the valves break and they leak? Blood goes up, blood runs back down, okay? That's important. We'll talk about that in a second. So again, acute and chronic expansion and obstruction. So when we're talking about acute obstruction, you're talking about DVT. You all know that term, deep vein thrombosis, okay? Blood clot forms, causes an obstruction in the veins, increases the pressure in the vein, hard to get fluid up past the obstruction, and you get pain, swelling, okay? The other risk for that is piece breaks off or embolizes, and then you get a pulmonary embolism. So that means a chunk went to your lungs, so it went through the heart and landed in your lungs. So that's a PE. On the chronic side, you have what we call post-thrombotic syndrome, which is basically if you had a clot and your body tried to reabsorb it, it's never 100%. So you always have this residual scar on the inside, which damages the valves. And so you have the partial obstruction and you have the vein valve dysfunction, and that causes some of this to and fro, back and forth flow, high pressure over time, and that's what we call post-thrombotic syndrome. And then you could have venous insufficiency is kind of a mild version of that, and extrinsic compression. If you have other organs like an aneurysm pushing on a vein, you can have partial obstruction. Expansion, again, venous aneurysms are very much less common, but you can get them, they can develop, you can get traumatic expansion or on an acute basis or rupture of a vein. And then expansion on a chronic basis, we all know essentially is varicose veins. So for DVT, blood clots in the deep vein system, most commonly in the pelvis or abdomen, typically, but most commonly in the legs. That's where you get it from. 250,000 people get DVTs. Mortality is from the pulmonary embolism. So why do we put you on blood thinners? To prevent you from getting a PE and dying. That's the real reason. It's got really nothing to do with the obstruction in your leg. It's to prevent you from dying from a PE. That's why we treat you. 30% of recurrent DVT within the first 10 years after an event. So if you had one DVT, you're at risk for getting another DVT. Why? Kind of makes sense, because you don't have complete flow, you have partial obstruction, and you have some resistance to flow, and you're going to, in a low pressure system, it's more prone to clotting. How does a DVT present? Pain, no pain, swelling, no swelling, PE and death. So you can present by dropping dead, and you had we found you had a DVT and a PE, and I've known people who've had that happen. So it's not in young people that can happen too. So we've all heard the horror story. Somebody takes a plane flight and then they drop dead. Okay, they died likely of a DVT and a PE. So if you think about it as a doc, if somebody's giving you some kind of vague symptoms and it smells like it could be a DVT, you're going to check it out. You're all getting a venous ultrasound because it's cheap and easy, and there's a lot of downside if you miss it. So usually it's pain and swelling, redness, something that looks like congestion because you've got an obstruction in the vein. So blood gets in just fine, has a hard time getting out. That's what it's about. And then why do clots form? Well, you need basically 3 conditions, and we call this Virchow's triad, but it's basically stasis, injury to the inner lining of the vein or the endothelium, and hypercoagulability of the blood. meaning there's something in there that's making it a little stickier. If you got 2 of those 3 at least, you're prone to getting a blood clot. 10 times increased risk with all those things: major fractures, joint replacement, major surgery, major trauma, spinal cord. Why? Think about it. All those patients, they're not going to be moving. Their system is going to be ramped up to clot from the injury, right? And they likely have endothelial disruption somewhere, which exposes tissue factor and kind of turns the system on. High risk. You got all 3 at once. You know, you got a little bit less risk with some of these other procedures, but things like congestive heart failure, cancer, and chemotherapy, you're killing the tumor tissue. It's ramping up your clotting factors. So we see that quite frequently. Cancer patients on treatment getting DVTs. Pregnancy and childbirth, and hormone replacement for contraception. So those kind of things all put you have a DVT risk. And then there are genetic and inherited conditions. That just means those clotting factors that are inside you or conditions are either ramped up or you're prone to clotting. So there's a whole list of those as well. And then again, a previous history of DVT also carries an additional risk of DVT. And the least risky, but still possible, is, prolonged car travel, air travel, bed rest, older folks, obese folks. So warmth, redness, leg pain, swelling, or no symptoms at all. I mean, painless swelling. The swelling part of it, even if there's no pain, it's one-sided. It's typically one side gets the obstruction. Now, if you had a high enough obstruction, let's say in the iliac veins or the vena cava up high in the pelvis, but your swelling would be really high, right? Because blood's moving uphill towards the heart. So if the dam is at this level, the swelling is going to be downstream, right? Or in front of that, if you will, or upstream, I should say. So the whole limb would be swollen. If you got swelling kind of in your calf area to your knee, you could have a clot up in your thigh, because that's the direction of flow and where the obstruction is. So that kind of tips us off as to where we think the clot is. So if you think you got a DVT, we do, like I said, an ultrasound, and there's also a blood test that a lot of people do in the ER called a D-dimer. And what that is I think I alluded to this earlier, is, clot forms and your body tries to reabsorb it. So our bodies are actually making clot all the time. You make a little bit, you break it down, you break it a little, break it down. And as the clot breaks down, you get these byproducts or split products. And D-dimer is one that we can measure. So if you present to the ER and they're concerned about a DVT, they do that blood test. Your symptoms may not be that dramatic, but your D-dimer level is elevated. That suggests that you've had some sort of ramped up clotting going on. So that prompts more of an investigation or treatment for a DVT, if you will. And then if you think you have a DVT or you're coming with shortness of breath, you get a chest CT to make sure you haven't have a pulmonary embolism. Treatment is anticoagulation. Again, it reduces the risk of extension, embolization, and tries to reduce chronic valve damage, but that really doesn't happen so much, if you will. If you have large vessel obstruction, like from the groin up, we tend to be a little more aggressive in terms of actually breaking the clot down, called thrombolysis. And that tends to give better outcomes and preserve higher up valves. But from the leg down, the groin down, it's blood thinners. So, all right, this is you're going to be tested on. This is the clotting cascade. And so it's complicated, but the bottom line, it's actually fairly simple, is you got platelets that get activated, they make a plug, and then you get a scaffolding of proteins that basically cause a structure, and then fibrin, which locks it in. So that's what a clot is all about. So when we look at treatments for anticoagulation, the different compounds that we use basically target different parts of this system in order to act. So the old school way, we used to put people on what's called heparin, and then we used to put them on Coumadin or warfarin. Okay, warfarin is what we call a vitamin K dependent cofactor anticoagulant. So the action of warfarin, so heparin is short acting IV, quick acting, turn it on, turn it off. Warfarin takes several days to ramp up and get therapeutic, and then slowly gets out of your system over 2 or 3 days. And so that was the gold standard of anticoagulation up until about 10 years ago. But the heparin gave you the quick effect, and then warfarin, the 2, 7, 9, and 10 here, those factors are the ones that are the vitamin K dependent cofactors that got blocked. And that 2 to 3 days, because the attack on the half-lives were variable. Some of the half-lives were longer, some of them were shorter. So it took about 3 days that you had to overlap those folks. We have newer compounds now called direct oral anticoagulants, or DOACs, Eliquis, apixaban, Pradaxa, and they go directly to like 10A here. So they cut to the chase. This is the critical step where prothrombin and thrombin and fibrinogen get attacked. So they basically act on this final common denominator here, and then some of them act on the thrombin conversion at this step. So they go basically here and here rather than all of these. And that's currently what we treat people on. They are immediately effective. You don't have to get your blood tested, and it saves you 3 days in the hospital. So that's what we talked about. And the risk to treating people is bleeding, obviously. So that's why on heparin and warfarin you were monitored, and with the DOACs the bleeding is significantly less, and they're just, you take the dose and that's it. Now a little bit about varicose veins. So they're basically dilated superficial veins that you can see, and they're related to genetics and valve dysfunction. So if you've had an upstream obstruction, that can be a problem. If you have the valves just wearing out naturally, gravity brings the blood downhill, wear and tear over time, and then you can see these because they become visible and stretched out. Most of them are related to a family member. I mean, it's genetic, so you'll find a family member somewhere that's got it. We talked about this. Basically, as they become, bigger channels into smaller roots and finer roots, you get what's called telangiectasias, which are at the surface, the little spider veins that you see, reticular veins, and then the more bulky, ropey varicose veins. So it's vein valve failure and too much pressure causing high blood pressure in the system and recruiting other ways of trying to get those veins out. So when we approach this, basically what we're trying to do is identify the root of the problem, where is the insufficient valves located, and then tying it to, if you can tie it to a larger upstream vein, then when you treat these, you have to kind of start from there and work your way back. So if you have somebody who presents with smaller varicose veins and you don't interrogate the whole venous system, you could treat them with injections and they keep coming back and coming back and coming back because you've missed the feeder system, if you will, that's perfusing it. So we kind of work from the bigger veins to the smaller vein. Classic symptoms: tiredness, aching, heaviness, pain, and the unsightly, bulky varicose veins. And some people, if they're superficial enough, they can erode through the skin and you can get bleeding. So, that's another presentation with varicose veins. So what we do in terms of treatment, it just depends if people are symptomatic or not. People have varicose veins and they may not be bothered by it, and in which case you can keep an eye on them. If you don't like the way they look, they can be repaired or removed or fixed just because of the cosmetic reasons. But if you're having symptoms and it's complicated and you're being bothered by it, then that's an indication for treatment. So clinical exam, documenting of symptoms, ultrasound to look for the upstream obstructions, and you basically are trying to determine where the high pressure reflux is or the broken valves and work your way back. Objectives to therapy relieve symptoms and eliminate the abnormal route. And then after you've done that, you also can consider debulking any of the stretched out tissue. So if you repair or remove the vein or the main feeding vein or shut it off with a less invasive technique, sometimes if the veins are big and boggy enough, you still got a lump there. So we try to debulk those for people who they're bothered by. And those are the treatments that we offer. Compression stockings is basically putting pressure against it. It's not correcting the anatomy, but it's temporizing the symptoms. And they're only as good as you wear them. People who have compression stockings or have tried it, they all hate it. They're uncomfortable and they slide down. But that's the point of it, is trying to keep some pressure off of the veins, but it will help the symptoms because you're decompressing the veins, but you're not solving the problem. That's it. So, you learned a lot. Covered a lot of ground. Some terms you've heard, some you haven't. Yeah, you had a question.
By graded compression stockings, you mean that they're designed specifically for you as opposed to just buying them off the shelf?
No. Graded compression stockings means they have a pressure gradient in the stocking. So so you come to the doctor, and if the doctor orders a medical grade stocking for you, they're rated as 20 to 30 millimeters of pressure. And that means 30 millimeters of pressure at the ankle to 20 millimeters as you go up the leg. So that's kind of entry level, 20 to 30. And so most people, it's a combination of wearability and ability to get them on and not too tight. Okay? If you have wounds, like a venous ulcer, because there's so much pressure and it's compromised the skin and the skin isn't healing, then we would ramp you up to a 30 to 40. 40 millimeters of pressure at the ankle, 30 millimeters at the calf. Now, think about it. What's your arterial blood pressure? Somebody who's hypertensive, it's 120, right? Or not, no, normal people are 120. It could be 220 if you're hypertensive, okay? So most of us are in the 120 plus range, right? So if I put 40 millimeters of pressure on your ankle, I'll say, oh, it's cutting off my circulation. No, it's not. You got to get, that would be a 120 to 140. Doesn't exist. So yeah, they're tight, you'll notice it, but that's what it means. So even with a tight stocking, and they go up to 40 to 50. 50 at the ankle, 40 at the calf. So those are people with big legs, big ulcers, not healing, chronic complications. You can get into those. But a graded compression stocking means the stocking that you buy is rated at that. What you're going to get off the shelf, the white ones that people see, they're called TED hose. They're 8 to 12, okay? So that's what the rating on those are. And you can get some over-the-counters that are kind of in the 10 to 15 is mostly what you're buying, and some of them may not have a pressure on it. So if you have venous disease and you're supposed to wear stockings, you need to be in a 20 to 30 at a minimum, okay? So that's legitimately what you should be looking for. Yeah.
I have a two-parter. So if you're traveling and you do have venous issues, okay, what do you recommend for traveling socks? And then the second comment was more of a comment than a question. D-dimers for seniors are slightly higher than D-dimers for the average person. So don't get freaked out if you're just a little bit above.
Yeah, there's a normal range that's age dependent, but generally speaking, it's elevated for your range. But it's not subtle. We're not looking at like 1 point above baseline. You're talking about a couple times above. It's going to be pretty significant if the D-dimer is positive. And so the question was, for travel, what do you do? Okay. So what I tell patients is, the first thing is no stasis, right? So if I'm on a plane, you want to get up and walk the aisle, you know, and you know, if you have venous disease, you want to walk a couple of times on a flight. So like, if you have legitimate venous disease and people are on a road trip, I say every hour or two, if you had a DVT, get out of the car, walk around, or get in the aisle and walk around. So you'll see people on the plane walking back and forth. You know, they're doing that. What you're doing right here is the rocking back and forth on your calf. Yeah, that's walking because you're moving your calf. Calf muscle pump is what we call it. That's what it does. So the calf muscle action pumps the blood uphill. So that is simulated walking you can do in a cramped airline seat without, if you're in the middle seat, you can't get out, you know. So,
Another part would be if you are had any type of surgery, it's good to get up and walk.
yeah.
Because you're moving those.
So we try to ambulate you early. So as a vascular surgeon, you know, I've always looked at it as, you know, the DVT risk is a little less, even though it's major surgery, because A, I give you blood thinners. You're heparinized during my procedures because I'm in your vessel doing stuff. So that decreases your risk. And then we try to get you up. But even with the orthopedist, who nowadays, I mean, their major joint operations are almost like drive-bys, right? You go in the hospital and you're out that day, right? But they're trying to get you up and move you around. But even doing that, there's a high risk of DVT with those procedures or an arthroscopic procedure. So it happens, it's major surgery. But there's always been a push in surgery to ambulate people. It's not like in the 50s where you were like beached in the bed for a week. And that doesn't happen anymore. It's like you're out of bed the next day. And all my patients, you get 24 hours of bed rest and then you're up. You know, you're up and you're moving. And that is why, you know, we can anticoagulate you to prevent you from getting a DVT or reduce your risk, but we can also use what they call sequential compression devices, which are the leg squeezers. And they're just as effective in the post-surgical phase as blood thinner. So you're balancing bleeding and DVT risk. So there are alternatives to that. Yeah.
Yeah, many years, 25 trips to South America, 5 months each. I used to be Indiana Jones explorer. And then I started going to Italy when I got old. And about 5 years ago in Sicily, I got COVID. No symptoms whatsoever, except my legs swelled up like they were going to burst. I felt like I had holes poked all over me, must have been thrombosis. I walked it out for a couple of months. I had Tourette's syndrome. But I lost the strength in my legs. And this is something else, it's a back issue. But, and then peripheral neuropathy. But that doesn't bother me so much as just losing my strength. What's the prognosis, Doc?
Okay, patient over here has COVID, got leg swelling and pain and clots.
Yeah, the legs swell up. Nothing else.
Okay.
Just that.
So COVID, as you know, one of the presentations was thrombosis. So there are people who presented with horrific like artery clots, vein clots, lose limbs, because they went through that acute phase. So the whole virus response activated the clotting cascade and caused problems. So if you've had in a person who's had clots or massive clots, even though you're symptomatically improved, again, you could have issues with venous hypertension or the complications of that in terms of post-thrombotic syndrome is what we call it. So that would give you like the fatigue and the chronic discomfort related to too much high pressure in the venous system. So that would need to be worked up. But if you have an overlapping spine condition, that could be part of it as well. I would say, you know, venous workup, looking for clots and insufficiency, and then looking at your spine.
Out of respect for everyone's time, one last question.
Just when it's so curious, you know, that the blood that we pump from our heart, you know, it's in the artery form, it goes to those capillaries. And I would think by the time it that's what's pushing the blood back to the heart? Is it the muscle only, or is there still pressure?
There's still
in that
pressure.
artery?
Yeah, there's still pressure. So it's not like you're slamming it down to nothing and then you got the long walk back. It's like, you know, it's like you got enough force coming through because you do have pressure in your veins, you know, and then you have respiratory variation, so you have that, the breathing helps, you know, you got negative pressure in your chest, so it's almost like a vacuum. You're pulling and sucking blood up, and then you have the valves, and so it's all of that together that gets you the return system.
Probably speaking for everybody in the room, but we are very, very fortunate to have you and are grateful. So Dr. Ombrellaro, big hand.
Thank you.